Hello, I'm Gavin Nyman, orthopaedic surgeon and head of shoulder surgery at the Queen Elizabeth Hospital. I'm also senior lecturer employed by the University of Adelaide, involved in undergraduate teaching for the fourth year medical students and the 6 years. I've been asked to give a talk on the shoulder and the shoulder conditions that occur in the shoulder and a part of the assessment. And as such, I've divided it up into the way I assess a shoulder as an upper limb surgeon. In general, I like to use an assessment technique based in a simplified fashion. Whilst surgical sieves are always useful, particularly for the more difficult cases, it's very important to remember the particular diagnoses that can occur when assessing a patient. The example I give is that unless you know what you're looking for, you can't find a object in a room. And unless you know the diagnoses that can occur in a shoulder when you go to take a history and examination, if you don't know the possible diagnoses, then you won't know what you're looking for. And as such, I use a simplified technique to remember the possible diagnoses based upon what I call the rule of threes, which is an English technique. Apparently in English literature you can actually divide things up into three different objects or assessments. It's often used in storytelling, such as Goldilocks and the Three Bears and the Three Little Pigs, etc. Or in jokes, the three guys that go to the pub. And it's a very simplified way of actually trying to divide things up and subdivide things up into more complex. And that way, it's basically almost the same as you get with 2 to 3 degrees of separation when we talk about meeting people. So the rule of three is based upon how a patient might present. And I think, where would I see a patient if I was seeing a patient for an opinion? I either see them in a traumatic scenario, i.e. in A&E, or in an elective scenario, such as in a clinic. Now, sometimes it can be a mixed picture too. I mean, obviously, you often see patients on wards, but they're people who have already been through A&E or through a clinic to end up on the ward. So really, it's casualty presentation, traumatic, or elective presentation through the clinic, or mixed picture. And that's my rule of threes. Now, the rule of threes actually keeps going on throughout the whole of the assessment. It's not just purely for the subdividing the diagnoses, but it occurs in all aspects of life. Now, when we assess a patient, our assessment is made based upon a history, which helps us make the diagnosis, our examination, which helps us confirm the diagnosis, and then our investigations, i.e. 1, 2, and 3, the three options. As I say, history helps us make the diagnosis, examination helps confirm the diagnosis, and the investigations help us stage the condition, determine treatment options, and determine prognosis. When it comes to examination, in orthopedics we use the look, feel, move technique. Now, look, feel, move, again, is three scenarios. Now, we also add on to this a special test. When I talk about the rule of threes, by the way, you think of a Gaussian distribution where the most common number is in the middle, and then there's first one standard deviation on either side of it is actually where 95% of the data falls. Well, that's why I call the rule of threes the rule of 2, 3s, and 4s. We divide things up into 2, 3s, and 4s. When we go to investigations, we look at the more simplified techniques we might do. So obviously, once we've taken a history and examined a patient, simple investigations might include temperature, which if raised might make you think of an infection, blood tests, which again could help us exclude infection and also exclude other pathology, as well as then some more x-rays, which I think is the most important diagnosis as investigation tool in orthopedics. Ultrasound, which is useful for either injecting an area or aspirating it or looking for an abscess, and then MRI scans, which always aren't 100% reliable, can overcall the diagnosis, and often may not be required if the x-rays have given us the answer prior, or even the simple history examination. When it comes to treating a patient, really it comes down to 4 types of treatment anyway. Conservative, i.e. giving it time, along with or without hand therapy or physiotherapy. We could try injections, and then there's often surgery. As part of the time technique, we might involve splinting or immobilization. So as such, when we go to assess know the diagnoses that can occur in orthopedics in the upper limb, I've divided up into traumatic presentations, elective presentations, and the mixed picture. The traumatic ones are the easy ones. They can occur in nearly any area of the body. How does a patient present traumatically? Well, often they've had a trauma. They've been fallen off a bike, landed awkwardly while playing football, involved in a car accident, and they present with a one area that's locally tender. And the main things that can occur are either a fracture or dislocations in orthopedics. Now, there are sometimes people might present with a picture that looks like a traumatic presentation, i.e. sudden onset of pain, but actually it's hiding the true underlying cause, which is infection. And so I like to consider traumatic conditions as being either fractures, dislocations, or infections. In some areas too, it can include tendon lacerations as well, or ruptures, and it can occur in orthopedics in shoulders with acute tendon rupture, but that's probably a complication of a chronic elective scenario in the first place, or a complication of a dislocation. So what can be fractured? So first of all, there's three diagnoses once again. That same number 3 appearing once again in the scenario. But what can be fractured? Well, the obvious answer for what can be fractured is a bone. And how many bones make up the proximal shoulder, or the shoulder? Well, ironically, there's 3. There's the clavicle, the proximal humerus, and the scapula, or the glenoid, which also incorporates a glenoid. Now, what can be fractured in the clavicle? Well, we can divide the fractures of a clavicle up into 3 areas. Medial, where it involves close to the sternoclavicular or the sternoclavicular area, often sometimes difficult to assess unless you get a CT scan. The midshaft, which is a more common area and often common usage, occurs when people fall off bicycles. And that occurs 80% of the time. Or laterally, where there can be involvement of the corticoclavicular ligaments such that the end of the clavicle sits up more than normal. This is similar to an AC joint dislocation where the corticoclavicular ligaments disrupt and the whole end of the clavicle sits up. Going to the proximal humerus, what can be fractured there? Well, that can be divided into 3 areas as well. It can be the tuberosities, such as the great tuberosity pulls away. That often occurs after a dislocation. In this scenario, what happens is the rotator cuff is attached to the great tuberosity, and as the shoulder dislocates, the tuberosity comes away with it, being the weak link. So this is a complex scenario with a dislocation and a tuberosity fracture. Often the fracture might occur as the shoulder tries to dislocate and then reduces itself. These scenarios, if it's displaced, might need surgery. The fracture can also involve a joint surface, such as in this one, with a big defect in the proximal humerus, so posteriorly, where there's been a big dislocation and the actual humeral head has become dented, or it can involve the articular surface more proper, or it can involve the surgical neck, or a combination of all 3 areas. When it comes to a fracture of the scapula or glenoid, it's much easier. It either involves the whole scapular blade or body, and because there's such good blood supply around the scapula, this usually heals quite well, or can involve the glenoid surface. In this scenario, there's articular deformity. It can lead to arthritis later in life, or if that fragment is displaced, could make it prone to dislocate because some of the glenoid is missing. Now, dislocation is much the same way. When asked what can be dislocated in the shoulder, well, ironically, one of the 3 joints. How many joints are there in the shoulder? 3. Glenohumeral joint, the more common joint we hear about in the media when a footballer falls over and dislocates his shoulder. Dislocation can occur either anteriorly or posteriorly, or can go inferiorly as well. Usually the more common direction is anteriorly, but posteriorly can present after a seizure or epileptic seizure, or a fall on the outstretched arm with the arm abducted. In this scenario, there's what they call the tennis racket sign, where the ball looks, or the actual humeral head looks straight on, and there's like the actual humeral head looks like the body of the tennis racket, and the shaft, the humeral shaft, looks like the handle. And that's because the arm is so internally rotated in this scenario. And anterior dislocation is much more easier to identify. These require reduction, and then may need a stabilization procedure at a later date. The AC joint can be dislocated this way into the clavicle, where the corticoclavicular ligaments are disrupted and the end of the clavicle sits up. And depending on how much it sits up depends on whether it needs surgery or not. A simple strain or slight displacement might need more likely to need surgery than less likely to need surgery than a complete disruption where the whole shaft sits way away from the AC joint. Again, medially, the sternoclavicular joint can be dislocated, and it's sometimes more difficult to identify, and it's usually based upon a history and clinical findings, and then a CT scan might help identify it. And here in a CT scan shows the sternum, the left medial border of the clavicle, and the right one, the clavicle sitting posterior to it, and that's obviously going to put pressure on the trachea. Now, infection can involve 3 areas. It can involve joints, where it's called septic arthritis. Again, the 3 joints can be involved, the glenohumeral joint, the AC joint, or the sternoclavicular joint. It can involve bones, osteomyelitis. It involves one of the 3 bones, or it can involve soft tissues, skin or deeper layer. People with likely infections are probably those who are immunocompromised, such as diabetics, or suffering from a infection, overwhelming infection, or chemotherapy, or if they've been using intravenous drugs, where there's been blood-borne bacteria. They can also occur in the elderly or the young, particularly young in the bones because of the growth plates blocking the blood supply of the interosseous vascular channels, leading to almost pools of blood occurring close to the growth plates. Infection will present with severe pain, relatively sudden onset, not improving, but with a temperature, often with a temperature and high blood markers. So there are traumatic presentations, usually fairly easy to identify. The important one is not to miss the infection. Elective presentations are a little bit more difficult because you need to know the exact conditions that can occur in a shoulder, and that's what this talk's all about. The most common condition that occurs in a shoulder is rotator cuff spectrum. The rotator cuff are the four muscles that encircle the shoulder: the subscapularis anteriorly, which is the internal rotator of the shoulder; the supraspinatus superiorly, which is which helps initiate abduction, but really depresses the humeral head, holds it down into the glenoid cavity such that the deltoid can act upon it; and then the two external rotators, infraspinatus and teres minor. There is really a fifth muscle, the long-headed biceps, which is one of the heads of origin of the biceps, which runs through the shoulder joint and attaches to the top of the labrum, sitting in the bicipital groove, just between the space between the supraspinatus and subscapularis. This can also become inflamed and painful as well. Now, the rotator cuff conditions are a group of four conditions, but really it's three, bursitis or tendinopathy being the first one, that occur in the shoulder. The tendons become tendinopathic, or the lining become inflamed, usually from overhead work, and they may present with painful arc between 70 to 120 degrees of motion. The pain's worse at night, as you often feel laterally down the arm, and can be associated with overhead work. If it's a young person that gets this, it's obviously a bursitis. As the tendon starts degenerating, it's called tendinopathy. If the long-headed biceps is involved, it's called long-headed biceps tendinopathy. As the patient ages, they can go on to develop tears. This is hastened by the smoking, which can also cause people to age quicker. It more commonly occurs in supraspinatus, can lead to weakness in that direction of the motion, and occurs in older age group. And if the tear is significant, the humeral head starts subluxing out of joint, it can lead to secondary arthritis, which is stage 4 of rotator cuff disease. One of the other important diagnoses in the shoulder is arthritis. Of course, arthritis is degeneration or inflammation of a joint, and it's three main joints as we've described. The AC joint, which occurs with pain at the end range of motion as someone lifts their arm out, secondary to impingement of the end of the collarbone hitting the acromion, or pain on adduction from the same reason. They often present with a lump at that site, and can occur in a younger age group, often secondary to a lot of weightlifting or traumatic sports, and can be easily treated with either steroid injection or excision at the end of the clavicle. Sternoclavicular joint arthritis is also relatively common. It occurs in older ladies, occurs in older people, but also it's more not common in older ladies because they notice it because they're wearing a lower neck cut, and with a necklace they suddenly see a lump at the sternoclavicular area and worry there's something more sinister. It's usually benign and is quite common. The most significant arthritis in the shoulder is glenohumeral joint arthritis. This is a wearing away of the humeral head on the articular surface of the glenoid with associated pain. Now, arthritis can be, all types of arthritis can be divided into three main groups again. I like to consider primary arthritis, where the joint just wears away, almost a wear and tear of the joint. Secondary arthritis, which wears quicker, secondary to other causes, either post-traumatic, post-infected, following rheumatoid arthritis or another inflammatory arthritis, or post-metabolic. There really is a fifth diagnosis, of course, would be post-rotator cuff disease, which I've left off here as well. Then it can be the inflammatory arthritis, which the rheumatologist will tell you about. The rheumatoid being the most common, but also psoriatic and a myriad of other types of inflammatory arthritis. When it comes to arthritis in the shoulder, the treatment really depends upon whether the cuff is intact or torn. If it's intact, then the humeral head sitting in the glenoid in the appropriate position. And if you follow the actual medial border of the humeral shaft up to the medial border or the inferior border of the scapula, it forms almost an arch, so it's suggestive that the humeral head is not superiorly subluxated. Given there's wear here in subchondral cysts. This is primary osteoarthritis, and the treatment would be a standard shoulder replacement, replacing the ball with an artificial ball and with a stem, and putting a plastic socket in the glenoid. In the rotator cuff disease, often the humeral head's sitting up, in which case if you follow that line up, you will see an incongruity as a defect as the humeral head rises up. And the undersurface of the acromion is now articulated with the top of the humeral head. And the treatment for this is a reverse shoulder replacement, assuming in all these cases that people have failed non-operative measures, i.e. pain relief, analgesics, time, and anti-inflammatories. And if all that fails, then we go to a shoulder replacement. And a reverse shoulder replacement involves putting the ball where the socket is and the socket where the ball is. Further diagnosis occurs in the shoulder is frozen shoulder. Now this is a condition that does lead to stiffness in the shoulder. It can look like arthritis, but really is an unknown cause. It's more common in diabetics, and the 40 to 68 year also occurs in the 40 to 60 year age group. X-rays will always be normal. It's very common. No one knows why it occurs, and it's self-limiting. It goes through 3 phases of conditions: the freezing painful stage, where there's a severe pain but they still have good movement. An ultrasound at the time might show bursitis, but it's not caused by that. It goes in the frozen stage where the motion also drops off, but the pain might start to improve at the end of that phase, and that thaw is where everything starts recovering. I like to think of it as 4 stages. If we think of the amount of pain or the amount of stiffness being in the Y direction, and the X direction being time, initially there's no pain or stiffness, then they develop pain but no stiffness, then they develop pain and stiffness. The stiffness and pain continue until the pain starts improving, and then later on the stiffness starts improving. Really, with this condition, the treatment is the condition is self-limiting, but the treatment works better if in later stages. If the condition is taking too long to recover, then you can try measures to try and help it recover by trying physiotherapy and hydrotherapy, trying a steroid injection of the joint, and at a later date, surgery such as manipulation and capture and release of the scar tissue around the shoulder, or a capture and release, releasing the tightened capsule which occurs in a frozen shoulder. Can be of use, but really the longer one waits to do treatment, the better they do. Now, other things that can occur causing shoulder pain are referred pain from the neck, such as say a C5 nerve root entrapment, which can also lead to weakness and motion secondary to a radiculopathy, or thoracic outlet syndrome, where the nerves in the shoulder are caught as they pass underneath the clavicle by an accessory rib or fibrous band from the cervical rib, trapping the nerve, particularly in the abducted position, and leading to either weakness or loss of sensation in the hand, or even some vascular changes too, as the arm is abducted. Now, the mixed picture is really an instability picture. Now, this is partially covered in the dislocations, but recurrent dislocations really becomes now an elective scenario, i.e. acute traumatic dislocations which keep recurring becomes an elective scenario. They present a clinic with recurrent dislocations. The reason people dislocate relates to the fact that the humeral head is 4 times bigger than the glenoid socket, and the glenoid socket is made larger by having this fibrous tissue around it, extending the size of the glenoid socket. At the top of the glenoid, that fibrous tissue known as labrum is the insertion of the long-headed biceps. But if the fibrous tissue tears, and as usually happens on the first dislocation, then it often doesn't sit back in the correct position and predisposes the humeral head to want to subluxate out of the shoulder again and again. Here's a picture with the glenoid orientated horizontally. We can see the labrum where it's been reattached to the edge of the glenoid. It's been probed by this metal probe. Now, we can subdivide the dislocations into unidirectional, which occur in one direction, or multidirectional, which occur in multiple directions. Possible directions for dislocation are the same possible directions of the tear of the labrum, which is really anterior, which is the most common one, following a dislocation with the arm in the abducted external rotated position. Posterior dislocation, as we talked about earlier, or inferior, which is less common, often combined with the anterior ones. The unidirectional usually following a traumatic incident, and as long as it's repaired, usually recover. 95% of dislocations in the younger age group will go on to get recurrent dislocations. Sorry, that's 85% of dislocations in the young age group will go on to get more recurrent dislocations unless treated. And as such, there is a good argument for treating them early. Of course, recurrent dislocations can lead to secondary arthritis. Multidirectional instability, however, is a more complex scenario because it relates to not only tears of the labrum, but it also could relate to underlying ligament laxity. Often these people have either previous ACL injuries or family history of dislocations, or history of other joint dislocations or hyperextension of the fingers. And then we need to assess for signs of ligament laxity. In all cases of shoulder instability, physiotherapy has a low success rate in recurrent dislocations, and therefore surgery may be warranted in those patients that keep dislocating. Now, there's another type of instability pattern, or I consider as an instability pattern, is the superior labral tears, where the labrum tears at the top of the glenoid. Now, as opposed to this being a dislocation or instability, it relates to the biceps tendon pulling on the labrum away from the glenoid. This is known as slap tear. In the early 2000s, one of the orthopedic surgeons assessed this as being a cause of chronic pain in the shoulder. And however, it's now subsequently shown to probably be in a lot of scenarios either a unrelated tear, which doesn't cause the pain, or not, or often just incidental. And therefore, repair is not always indicated. If we were to repair any of these labral tears, the usual way is to roughen up the bone of the edge of the glenoid and put in some anchors and tie the labrum back to it. In a recurrent dislocator, for the anterior dislocator, sometimes we put a bit of bone there from the edge of the coracoid to help stabilise it. On the superior labral tear, rather than repair the labrum, sometimes we might opt to actually just release the biceps from the labrum and reattach it outside the shoulder, known as a biceps tenodesis. These are all techniques and more advanced techniques to be aware of in the shoulder, which are probably beyond the level of fourth year, but just perhaps to know that there is surgical indications. I hope this rundown of the assessment technique and the surgical indications, diagnoses will help you in assessing a shoulder and make it as background or a base to which to go on to do further reading regarding your shoulder conditions. Thank you very much, and I look forward to seeing you in the hospitals.